I'm Dr. Robert Jones, and in this lecture we're going to go over inferior vena cava assessment. Determining fluid status in a critically ill patient is essential since giving too little will increase morbidity and mortality, as will giving too much fluid. And it's important to remember that vital signs and physical exam are going to be unreliable in determining the need for fluid resuscitation. Looking back at your physiology class days, remember the Starling curve? Well, this will help you to understand why we give fluids. The reason that we're going to give fluids to a patient is to increase their stroke volume. Once their cardiac output or index starts decreasing with further fluid administration, it's at that point that we would stop. So here's a question. Physical exam is unreliable in determining need for fluid responsiveness. Will knowing the central venous pressure help us? And some for a while have thought that this was the holy grail for determining fluid responsiveness, but unfortunately it is not. The bottom line is that central venous pressure correlates poorly with blood volume. Central venous pressure or change in central venous pressure does not predict hemodynamic response to fluid challenge. And at any given central venous pressure, the likelihood that central venous pressure can accurately predict fluid responsiveness is only 56%. That's literally a flip of the coin. Therefore, central venous pressure is going to be a measure of right atrial pressure alone and not a measure of blood volume or of ventricular preload. So what about inferior vena cava assessment with ultrasound? Is that the holy grail? Looking at static assessment of the inferior vena cava with ultrasound, yes, you can determine central venous pressure by measuring the size of the inferior vena cava. There is good correlation between inferior vena cava size and central venous pressure in patients who are spontaneously breathing. However, the correlation is poor in patients who are mechanically ventilated. But what does this data do for us? Probably the static measurements are going to be very limited in helping us, since we already said that knowing what the central venous pressure is probably not going to be very helpful in determining need for further resuscitation with fluids. However, we can look at the inferior vena cava from a dynamic standpoint and look at its phasicity with respirations. And these dynamic parameters can be useful in determining where the patient is on the Starling curve. Now, inferior vena cava respiratory variation of at least 18% predicted fluid responsiveness with a sensitivity and specificity of at least 90%. And this could also be done in ventilated patients. So while this may not be the holy grail, this may give us a lot better indications in the emergency department as to who needs further fluid resuscitation, and we can have a better idea of who's on this ascending part of the Starling curve. Here's how the inferior vena cava correlates with central venous pressure. You can see here that if the inferior vena cava is less than 1.5 centimeters in diameter, but it collapses greater than 50% with inspiration, that the CVP is roughly 0 to 5 megahertz or millimeters of mercury. If the inferior vena cava is between 1.5 and 2.5 centimeters and collapses about 50%, then the CVP is about 5 to 10 millimeters of mercury. If it's between 1.5 and 2.5 centimeters, but it collapses less than 50%, then you're probably at about 10 to 15 millimeters of mercury. If it's greater than 2.5 centimeters in diameter with little respiratory variation, then you're probably at about a CVP of 15 to 20 millimeters of mercury. So let's now look at some of the exam essentials. To measure the inferior vena cava, you're going to want the patient in the supine position. You'll use the 2 to 5 megahertz curvilinear or phased array transducer, and in terms of patient preparation, none is required. Here is a sagittal view of the inferior vena cava. It's going to be obtained by placing the transducer to the right of the midline in terms of the patient's anatomy. So you're going to go towards the patient's right in a sagittal plane, indicator directed towards the patient's head, and that will give you this image here, anterior, posterior, head, foot, and here you can see the inferior vena cava going from proximal to distal. Here's a dynamic sagittal view of the inferior vena cava. You can see the hepatic draining in, but you can see the inferior vena cava here sagittally, and you can see the phasicity that is occurring with respiration. Now, where do you measure the inferior vena cava? I would recommend measuring it about 2 centimeters caudal to the insertion of the hepatic veins. You don't want to be too close to the diaphragm since the inferior vena cava is tethered at this point, but I would go about 2 centimeters caudal to the hepatic insertion, and you can use an M mode to help you in terms of measuring it and recording this in the medical chart. Here you can see the respiratory phasicity that's happening in this patient. You can see that the inferior vena cava measures 1.5 centimeters, but with inspiration collapses to about 0.68 centimeters. Here's a patient who was in congestive heart failure, and you can see that they have a dilated inferior vena cava, and you can see that even without measuring that there is essentially no respiratory variation that occurs. So this is a patient who would have an elevated CVP, and with the little respiratory variation being assessed dynamically, this is a patient who is not in need of fluid resuscitation. Now here's a patient who was hypovolemic due to a massive GI bleed. If you take a look at their inferior vena cava, you can see that it measured approximately 1.5 centimeters, but it collapsed almost 100%. So there is a great deal of respiratory phasicity here. This, combined with the fact that the patient had a hyperdynamic LV function noted with kissing ventricles, this was a patient who was in need of fluid resuscitation and did benefit from being given both crystalloid fluids as well as blood. So let's wrap this lecture up. Let's just go over some key points here. Remember, the reason to give fluids to the critically ill patient is in order to increase their cardiac output. So ideally, it would be nice to have cardiac output monitoring in the emergency department, but that is not a common thing for us to have access to. So therefore, we need to find some other surrogate in order to determine in these critically ill people who should we be giving fluids to and who shouldn't we be. Now, for a long time, central venous pressure was thought to be that holy grail, but it's not. CVP reading correlate poorly with fluid responsiveness. So when you do the inferior vena cava measurements with ultrasound, yes, inferior vena cava size does correlate with central venous pressures, but that is not going to help us. If we take a look at a dynamic assessment of the inferior vena cava, where we look at the size change with respiratory and the presence of respiratory variation, this seems to correlate well with fluid responsiveness, but remember, it's not going to be the holy grail. I'm Dr. Robert Jones, and this is the Focused Echo, Pericardial Effusion, and Tamponade Physiology lecture. Echocardiography is highly sensitive for the detection of even very small amounts of pericardial fluid. Now, it's important to remember that there are numerous causes for pericardial effusions, and echocardiography will not, based on the echo appearance, allow you to differentiate one cause from another. Echocardiography is also highly useful in determining the findings of tamponade physiology, and that's what we're going to be covering in this lecture. Causes of pericardial effusions include infectious, malignant, inflammatory, and traumatic etiologies. To evaluate for a pericardial effusion, you're going to look for the presence of an anechoic or echogenic fluid collection adjacent to the heart. This is a subcostal window in a patient with bacterial pericarditis, and you can see that there's anechoic as well as echogenic areas within the pericardial fluid collection. Remember, these effusions can be diffuse or they can be loculated. In patients who have undergone recent CABG or other open heart procedures with pericardotomy, it's not uncommon to get loculated effusions. In patients with smaller effusions, it may require that you scan multiple windows in order to confirm that it's a pericardial effusion versus another etiology for a surrounding fluid collection. You can evaluate the effusion for size. A small effusion would be one where during diastole it's less than 1 centimeter in width at its widest. A moderate effusion is going to be between 1 to 2 centimeters in width at its widest during diastole, and a large effusion is going to be greater than 2 centimeters in diameter during diastole. Now remember, as we talked about in the trauma module, size doesn't matter in the trauma patient. The presence of an effusion is the most significant finding in these patients, since most of these are otherwise young, healthy people with fluid, naive hearts. And here's an example in a medical patient that during diastole, we measured the effusion, and at its widest here, it was 1.68 centimeters. Now you can measure the effusion wherever you want, since effusions can be either diffuse or loculated, so you're free to measure this wherever you want. But you want to determine its widest measurement. Here's a patient with a moderate effusion. It was between 1 to 2 centimeters at its widest during diastole, but you can see that this is a diffuse effusion. It extends all the way around the heart. Now here's a patient on the apical 4-chamber view who has a large echogenic effusion. This is a patient who had underlying cancer, and that was the etiology for his effusion. But this measured greater than 2 centimeters at its widest, and it is circumferential. Now here's a patient who had undergone a prior open heart surgical procedure. You can see that there's an adhesion here, and you've got a loculated effusion along the left side of the heart. You've also got some fluid along the right side of the heart, but it doesn't connect because of this adhesion here. Sometimes these effusions on the left side can become large enough that you can get tamponade from an isolated left-sided effusion. So always consider the presence of a localized effusion, particularly in a trauma patient or in a patient who has undergone recent open heart surgery. Now here's a patient who has some pericardial thickening. You can see on this subcostal window that there is a large circumferential fluid collection. You've got right atrium, right ventricle, left ventricle here, and some of the left atrium here. But you can see that the pericardium is thickened. Now echo is not sensitive necessarily for the detection of pericardial thickening. Pericardial thickening, when you see it, can either be diffuse or focal, and common causes include prior cardiac surgery, radiation therapy, or prior pericarditis. And this was a patient who had had prior radiation therapy. Key point I want to bring up right now, so that this stays in your mind, is that rapidly accumulating pericardial effusions can cause tamponade physiology when small in size. So the more rapid the fluid is accumulated, the more likely you're going to get tamponade physiology at a smaller size. So keep that in mind, that even small effusions, if they accumulate rapidly, can cause tamponade physiology. Now let's look at some of the pitfalls of this exam. Remember, anything that results in an anechoic or echogenic space adjacent to the heart is at risk for being confused with a pericardial effusion. False positives can include pleural effusions, ascites, pericardial cysts, and epicardial fat pads. Now here's an apical 4-chamber view, so right ventricle, left atrium, right atrium. Here you can see that this patient does have a very small pericardial effusion, but you also see this large fluid collection adjacent to the right side of the heart. That is a right pleural effusion. Now, fluid adjacent to the right atrium in the apical 4-chamber view can be caused by either pericardial or pleural fluid. So you may need additional views when you see something like this, but this patient had both. If you didn't have the pericardial effusion here, you may be very tempting to just jump at this fluid collection right here and immediately call it a large pericardial effusion. Now, differentiating a left pleural effusion from a pericardial effusion can be challenging at times. The parasternal long axis window is the most useful if there's debate between whether it's a left pleural effusion or a pericardial effusion. Here you've got a left parasternal long axis window. You've got right ventricle, left atrium, aortic outflow tract, descending aorta. Here you've got a pericardial effusion, and you know it's going to be a pericardial effusion because a pericardial effusion is going to go between the back wall of the heart and anterior to the descending aorta up towards the AV groove. A left pleural effusion is going to follow along the back wall of the heart, but it's going to stop at the descending aorta. So here you can see pericardium, pericardial effusion, left pleural effusion. So this is a great window for aiding in distinguishing between the two fluid collections. Here's a parasternal long axis in a patient with a very large left pleural effusion. You can see that it stops shy of the descending aorta and it just kind of curves around right here. So there is no pericardial effusion present here. This is all a large left pleural effusion. There's a parasternal long axis in a patient with a pericardial effusion. You can see the fluid collection anteriorly. You can follow it along again posteriorly, but you see that this goes between the back wall of the heart and the descending aorta towards the AV groove here. So this is a pericardial effusion. Now, epicardial fat is going to be an isolated echo pore space along the right side of the heart anteriorly. Pericardial effusions are going to tend to be both anterior and posterior. The other thing you notice is that even though there's this echo pore space right here, you can see that there's fixed echoes within there that have a kind of geographic or a lattice appearance within them, which is what you would expect with fat, and they move in a symmetric fashion between systole and diastole. But in a patient who is a trauma patient and you're worried about an echogenic pericardial effusion, you may have to do a backup window such as the parasternal long axis window in order to confirm that this is not a pericardial effusion. Here's a patient with no pericardial effusion, just an epicardial fat pad. And if you take a look at the subcostal window here, you can see right ventricle, left atrium, some of the right atrium over here. And you can see that there's this echo pore area right here along the right side of the heart. And again, you can see that there's fixed echogenic appearance within there, which is what you would expect with fat. And it's fairly consistent between systole and diastole. If you had doubts that this may be an echogenic effusion, then what you would do is do a parasternal long axis window. Here you can see that fat pad anteriorly, but if you follow the heart posteriorly, you see no evidence of a pericardial effusion. So this was all an epicardial fat pad. What's a false negative? Well, basically missing a small pericardial effusion. If you've got a small effusion, you may need multiple windows in order to really rule out the presence of fluid or not. Here was a patient that had a very small pericardial effusion. You didn't see anything along the left side, and you really only saw this just right along the right heart border here. Now, in a medical patient, this would not be large enough to cause tamponade physiology, but this would be something you would not want to miss in a trauma patient. Let's look now at tamponade physiology. Pericardial pressure is dependent on the rate of accumulation as well as the overall volume. Now, tamponade occurs when the pericardial pressure exceeds the intracardiac pressure. So cardiac compression is going to be most evident during the phase of cycle when the chamber pressure is at its lowest. Key point, at the end of the day, tamponade is going to be a clinical diagnosis. Echo may help provide supportive information, but you have to rely on the clinical exam also. Here's a clinical pearl that's supported in the cardiology literature. that patients with large pericardial effusions and hypotension should be treated as tamponade regardless of the additional echo findings. Echo findings of tamponade physiology include right atrial systolic collapse, right ventricular diastolic collapse, a plethoric or dilated inferior vena cava, and changes in right ventricular and left ventricular filling velocities. On our focused echo, we're going to concentrate on the first three findings of right atrial systolic collapse, right ventricular diastolic collapse, and the presence of a plethoric inferior vena cava. Here we have a patient on an apical four-chamber view who has a large pericardial effusion, and what you can see here is that there is right atrial free wall collapse and systole. So take a look at that for a second here. See how that's buckling in when the pressure is at its lowest? Now this is a sensitive and specific finding for the diagnosis of tamponade physiology. Ideally, collapse should be present for more than 1/3 of systole, and this is going to be best seen on either the apical or the subcostal windows. Now here are two apical four-chamber windows. On the left here, we have a patient who has normal cardiac function with absence of any pericardial effusion, and there is no tamponade physiology. Notice the appearance of the right atrium between systole and diastole. Note here in this patient, though, with tamponade physiology and a large effusion, note the free wall collapse of the right atrium during systole. Let's take a look now at right ventricular free wall diastolic collapse. This is going to best be seen on the parasternal long axis, parasternal short axis, apical, and subcostal windows. So really you'll be able to see this on most of the windows. This is a less specific or less sensitive but more specific finding than right atrial systolic collapse for the diagnosis of tamponade physiology. In patients with right ventricular hypertrophy, this finding may not occur or be seen. Here's a patient on a subcostal window. You've got a swinging heart, you've got a very large pericardial effusion, and you can see that there is right ventricular diastolic collapse. Note the buckling or invagination of the wall during diastole. Here's a subcostal window in another patient with an echogenic effusion, and you can see here that there is right ventricular diastolic free wall collapse. Note the buckling and invagination of the wall here. This patient had tamponade physiology from an echo as well as clinical standpoint. What you'll frequently see with tamponade physiology is elevated right-sided pressure, so you'll see a plethoric or dilated inferior vena cava with loss of respiratory variation. Here you have a dilated inferior vena cava, and as the patient sniffs, there's very little respiratory variation seen. So this is another finding that's supportive of the diagnosis of tamponade physiology, but it is not specific. This concludes the pericardial effusion and tamponade physiology lecture.